Shoulders and knees are the two most common joints in the body that patients will seek help for. They have shoulder pain. They can't reach above their head. They're having difficulty taking care of their children. So it's really impacting quality of life. And it will drive patients to go see providers. The providers that understand the importance of visualization for needle precision is key. That's what I focus on at my injection training. It's one thing to watch a video of how to do something. It's completely different when you have the transducer for the ultrasound in your non-dominant hand. That thing is slippery. It's a technique on learning. And then how do I get the needle trajectory exactly where I want it? This particular injection I like to call the PGH, posterior glenohumeral. With this, it is the #1 shoulder injection you'll do all day long. It is intra-articular, so you're actually going into the capsule of the shoulder. Patient is upright seated, I think is the easiest way to do this. When you're palpating, you're following the acromion, and then on the posterior side, there is a sulcus right here on this posterior, just distal of the acromion. So when I bring my transducer around, you can see the humeral head. You can start to see on the bottom right side of the screen is the glenoid. So this is the glenoid right here. And you can see the humeral head coming around this way. This is skin, adipose, deltoid, and infraspinatus. And then this is the humeral head here. Again, if I were to have her rotate slowly, elbow in, and slowly rotate your arm, you can see the humeral head moving. And you can also see the infraspinatus moving. The deltoid and the glenoid do not move on this PGH injection. This is one you're going to want to be very comfortable with. So now that I have identified my two bony landmarks, I am holding my orientation to my left, and that is the left side of my screen. I am imagining a cup of water on my horizontally placed transducer. I am now cleaning the skin with alcohol and chlorhexidine. You could also use betadine. Here we go. We are going 90 degrees towards the coracoid, next to the transducer without touching it. Little pinch, 1, 2, 3. And you can see that needle coming down, and I'm right next to the humeral head in that joint space. Shoulder's the most complex joint of the entire body. What are red flags? What should I not be injecting and why? And so these are all things that I cover in the class. How do I do orthopedic tests? How do I narrow down exactly where the pain generators are? So where do I put the needle? These are all things that I go through: differential diagnosis, common pathologies, orthopedic testing, plus the hands-on practice of the skill set, precision needle placement for deployment of whether you have orthobiologics, regenerative, or you have a corticosteroid, you have an all-natural anti-inflammatory. What you put in the syringe is up to you. It's the technique and skill set, and most importantly, provider confidence. Confidence comes with repetition, and it comes with hands-on training. Watching a video is not the same as actually getting in and holding the needle, holding the transducer, coordinating the two for your brain, and getting a great patient outcome.